Viral hemorrhagic fevers are a diverse group of animal and human illnesses in which fever and hemorrhage are caused by a viral infection. VHFs may be caused by 5 distinct families of RNA viruses. The families Filaviridae, Flaviviridae, Rhabdiviridae, and several member families of the Bunyavirals order such as Arenaviridae and Hantaviridae. All types of VHF are characterized by fever and bleeding disorders, and all can progress to high fever, shock and death in many cases. Some of the VHF agents cause relatively mild illnesses, such as the Scandinavian nephropathia epidemica, while others, such as Ebola virus, can cause severe, life-threatening disease. Signs and symptoms of VHFs include fever and bleeding. The severity of symptoms varies with the type of virus. The VHF syndrome and the South American hemorrhagic fevers caused by arenaviruses, but only in a small minority of patients with dengue or Rift Valley fever. 5 families of RNA viruses have been recognized as being able to cause hemorrhagic fevers. The pathogen that caused the Cocalistli epidemics in Mexico of 1545 and 1576 is still unknown, and the 1545 epidemic may have been bacterial rather than viral. Different hemorrhagic fever viruses act on the body in different ways, resulting in different symptoms in most VHFs. It is likely that several mechanisms contribute to symptoms, including liver damage, disseminated intravascular coagulation. This reorganization creates intercellular gaps in endothelial cells. The gaps lead to increased endothelial permeability and allow blood to escape from the vascular circulatory system. The reasons for variation among patients infected with the same virus are unknown but stem from a complex system of virus-host interactions. Dengue fever becomes more virulent during a second infection by means of antibody-dependent enhancement. After the first infection, macrophages display antibodies on their cell membranes specific to the dengue virus. By attaching to these antibodies, dengue viruses from a second infection are better able to infect the macrophages, thus reducing the immune system's ability to fight off infection. Definitive diagnosis is usually made at a reference laboratory with advanced biocontainment capabilities. The findings of laboratory investigation vary somewhat between the viruses, but in general, there is a decrease in the total white cell count. The hematocrit may be elevated. The serum urea and creatine may be raised, but this is dependent on the hydration status of the patient. The bleeding time tends to be prolonged. With the exception of yellow fever vaccine, neither vaccines nor experimental vaccines are readily available. Prophylactic VHF isolation guidelines dictate that all VHF patients a battery-powered, air-purifying respirator, or a positive pressure-supplied air respirator to be worn by personnel coming within 1.8 meter or phenolic disinfectants. Medical management of VHF patients may require intensive supportive care. Antiviral therapy with intravenous ribavirin may be useful in Bunyaviridae and Arenaviridae infections. The VHF viruses are spread in a variety of ways. Some may be transmitted to humans through a respiratory route. According to Soviet defector Ken Alibek, Soviet scientists concluded China may have tried to weaponize a VHF virus during the late 1980s but discontinued to do so after an outbreak. The virus is considered by military medical planners to have a potential for aerosol dissemination, weaponization, or likelihood for confusion with similar agents that might be weaponized.